Maureen, for the invitation to speak today, and certainly Alona for passing along my name. It is such an honor to speak with all of you. I am a pediatric otolaryngologist at UCSF, and I work with Dr. Frieden with our vascular anomalies team. It's one of my favorite parts of the oh good, I'm a co-host now of the clinical work I do, because I'm just so inspired by the community, the vascular anomalies community, and really just inspired by your commitment to your kids, and it's really incredible. Okay, let's see here. Let me do a screen share. Okay, how is that? Does that look okay for everyone?
Perfect. Yeah.
Okay, fabulous. So I was asked today to speak a little bit about hearing in patients with FACE syndrome, and so I have about 15 minutes to speak, and so I wanted to basically, I know that many of you have very young children and infants, and many have older or even adult children. So I wanted to sort of keep things at a level that gave you some good general information about hearing. But I know you are an incredibly well-educated group, so I wanted to bring everybody up to speed on kind of my assessment of the data that we have at this point in time, and kind of what how that impacts the recommendations that we make for patients, and then talk some about recommendations for testing and treatment for hearing loss, specifically in the context of patients with FACE syndrome. So first question is, how do we hear? And again, this may be, you know, a little bit of oversimplification for the folks in this conference, but we'll just start there. So basically the ear is divided into the external ear, which is the part you can see outside, and then the ear canal all the way to the eardrum. That's the external ear. Then there's a cavity called the middle ear. Okay, that's the area right behind the eardrum, and that's where the bones of hearing sit. And then there's the inner ear, which is an organ called the cochlea. And the way that hearing works is sound vibrations come in through the external ear canal and hit the eardrum. And the eardrum transmits those vibrations through the bones of hearing into the inner ear, into the cochlea. And what the cochlea does is transforms those mechanical vibrations into an electrical signal that goes through the hearing nerve into the brain. So in order to hear normally, you have to have an open external ear. You have to have an eardrum that's intact. You have to have air in the middle ear space behind the eardrum. You have to have an intact chain of bones of hearing. And then you have to have a functional cochlea, inner ear. And you also have to have a hearing nerve that is functional. So it's a sort of multi-step process. So the first check of hearing in any child is typically the newborn hearing screen. In the US, rates of newborn hearing screen coverage are about 95%. And there's two different tests that are used to confirm that a newborn can hear. One is called the otoacoustic emissions, and the other is auditory brainstem response. For a long time, otoacoustic emissions was the primary test because it's quick and easy, but you can have a lot of false positives and false negatives with that test. So auditory brainstem response screening is a little bit more the gold standard. The reason I'm going into this nitty gritty is that many patients with FACE who have been found to have hearing loss actually have passed their newborn hearing screen with otoacoustic emissions, and I can explain why that may be. So for otoacoustic emissions, what is done is a sound is delivered through the ear canal, and that sound stimulates the cochlea, and there are what are called outer hair cells in the cochlea that distort the sound, and then a reflected sound or an echoed sound comes back and is picked up by a microphone on the device. And so if otoacoustic emissions are present, then you know that you have a functional system from the external ear canal, the middle ear, and the cochlea. The problem with the otoacoustic emissions is they do not assess the hearing nerve. So if you have a problem with the hearing nerve, then you can have normal otoacoustic emissions, but not actually have sound getting to the brain. The better study for screening is auditory brainstem response testing. So sound is delivered again through the ear canal, and it stimulates vibrates the eardrum, vibrations through the bones of hearing into the cochlea. And what auditory brainstem response measures is actually the electrical signal through that hearing nerve going to the brain. And so an electroencephalogram device picks up that signal, and then you have confirmed hearing. All right. So those are the tests that are typically done before babies leave the hospital. I won't go too much deeper into other reasons for false positives and false negatives, but just to give you some background on how we can tell if babies who can't really participate in hearing tests can hear. So these tests are great for newborns. Once children get older, they're a little bit less reliable. And so once babies are able to participate in a hearing test, then we move towards what's called behavioral audiometry. Depending on the baby's age, there's different techniques that pediatric audiologists use to condition children to respond to sound, but experienced pediatric audiologists can actually get really pretty reliable data on babies as young as 9 months. In terms of what kind of information do you get from the audiogram, the behavioral audiometry, what you get is an audiogram. And so this is sort of a diagram of a template for an audiogram. And what is done is hearing is tested, typically starting at the low frequencies. They say the low notes on the piano and going from low to high. And the audiologist will start with a loud sound and then record the loudness of the sound when the child can no longer hear that sound. And then the child gets a diagnosis of normal hearing versus mild, moderate, severe, profound hearing loss. Okay, so that's just some background on how we hear and on how hearing is tested in babies and children. So the question is, how does face impact hearing? So like everything, there's not as much data as we wish there were. In my looking at the literature over the last couple of weeks preparing for this talk, there are sort of four case series that present information about hearing loss in patients with FACE, and there's actually one survey as well. So I'll talk about all this information, but obviously, the caveat is that a lot more study is needed, and so these are sort of individual patients' experiences. Okay, so I'll start with this survey that was published in Pediatric Dermatology back in 2019, called Natural History of Face Syndrome, a survey of adults with FACE. So they sent a survey to 75 adults, 18 responded. They were all over 18, average age was 24 years. And they had a question about hearing, and 6 of the 18 reported some hearing loss that impacted their life. They also had a question about hearing aids, and only 3 of the 18 were reported to have been fitted with hearing aids. So that's sort of helpful to get a sense of how impactful is this on adults. The data, particularly about imaging findings and hearing loss, comes from these 4 case series. Duffy from 2010, Bangiev from 2017, Mamluk from 2018, and this study here with Mark Mamluk and my partner Chris Rosby was our group at UCSF, and then another report from Polanski in 2019. So I'm trying to present these patients. I'm not going to just talk about each study individually, but rather kind of present the patients who fell into different categories of different types of hearing loss from each study. So, generally the question is sort of how does FACE impact hearing? And, basically hemangiomas can grow in locations that interfere with the hearing. And when hemangioma is found in the cochlea area or the inner ear, that results in what's called sensory neural hearing loss. And so in the audiogram, we can differentiate between hearing loss that's related to an inner ear cause versus conductive hearing loss, which is hearing loss related to a problem with the sound getting in through the ear canal, the eardrum, or the bones of hearing. So in terms of the reports of patients with sensory neural hearing loss and FACE, I'll start by presenting this report from Bangiev. This is a group from the University of Utah, and this is an infant who was started on propranolol at 7 weeks. On the right side of your screen, you'll see an MRI scan. So at the top of the screen is the front of the patient's face. You can kind of appreciate the developing teeth within the upper jaw. And then it's as though the patient is lying flat with her feet facing towards us. And so what you can make out on the screen here is this bright white lesion kind of right in the middle of this patient's head. That lesion is along the hearing nerve at a structure called the internal auditory canal, and it enhances significantly. And so in this patient with FACE syndrome, this was presumed to be hemangioma. The interesting thing about this particular patient is that initially this patient had an ABR study that they did not pass and actually was found to have profound hearing loss on that left side. But upon starting propranolol, the hemangioma not only improved substantially on the imaging, you can see compared to the image on the left and the right, that that large whitish mass in the internal auditory canal has decreased in size. This patient actually regained their hearing. So in infancy, she had profound left sensory neural hearing loss. And after 9 months on propranolol, she only had just some very mild residual left high frequency sensory neural hearing loss. Unfortunately, this is the only case presented that actually showed some improvement in hearing based on propranolol treatment of a hemangioma on the hearing nerve. But I think it points to the fact that I think there's a lot more study needed kind of on the mid and long-term outcomes of hearing in this population. Here's another patient who, again, had very diffuse segmental hemangioma. And this is from the Duffy group, published in 2010. Again, on the right side of the screen, you can see a bright lesion in the middle of this child's head, which is consistent with a hemangioma on the hearing nerve. Here are some other examples of hemangiomas seen on the hearing nerves. In the Mamluk paper, there were 3 patients identified that had sensory neural hearing loss related to these hemangiomas identified on the hearing nerves. Okay, so so those are the cases of sort of sensory neural hearing loss and nerve related hearing loss. Now, the other kind of hearing loss is conductive hearing loss, where the nerve and the inner ear are totally intact, but there is something obstructing the way the sound is getting into the inner ear. And there were 2 patients that had conductive hearing loss related to their face. This patient was presented in the Duffy paper from 2010, where here you can see on the right side of the screen, hemangioma was appreciated in this area here. This is actually not anywhere near the hearing nerve. This is near a structure called the eustachian tube. And the eustachian tube is the connection between the back of the nose and the middle ear space that allows air to get behind the eardrum. So, if you've ever been on an airplane and, plug your nose and clear your ears, what you're actually doing is pushing air through the eustachian tube up into that middle ear space. And so with the involvement of the hemangioma there, this baby was not able to equalize pressure in that space, and so had accumulation of fluid behind the eardrum and conductive hearing loss. And fortunately, that's a problem that can be corrected with a simple placement of an ear tube. Okay. This is a patient presented by Polanski, who this is a Brazilian case. So I think they maybe didn't have access to an MRI scan, but reported conductive hearing loss and also an enhancing lesion in the middle ear space. So the space behind the eardrum. And you can actually, this on the left side of the screen, this is a view of the tympanic membrane, and you can see some vascular stain kind of on the outside of the eardrum here. So another case where hemangioma was blocking the conduction of sound. Okay. So this is sort of a summary of all the patients in those 4 studies, and exactly what kind of hearing loss they had, and what correlates were observed in terms of their face syndrome symptoms. So the first 1, 2, 3, 4, 5, 6, the first 7 patients here are all patients who had sensory neural hearing loss. Some patterns. So all patients reported had left-sided hearing loss. One had bilateral, but I thought that was a very interesting pattern. The predominant segments that were involved were S1 and S3. Okay, some patients had S2 involvement, but predominantly those were the patterns. And again, the imaging findings were typically these hemangiomas of the hearing nerve and the internal auditory canal. The hemangiomas were often very small. In the Mamluk study, the largest dimension of one of the hemangiomas was 1.1 centimeter. So these are quite small lesions, and sometimes they were even smaller than that, to the point of one might have to look very closely at the imaging to appreciate them. The conductive hearing loss from that has been reported, I think, has similar patterns, but a little bit less consistency. But I think also interesting to kind of collate these data. So kind of in summary, again, I think a parent of an infant newly diagnosed with FACE might say, what's the chance that my child will have a hearing issue? Again, in the Stefanko survey, it was about 3 of 18 that did report using hearing aids. The Mamluk study, what I didn't mention is that what our team did was basically find all babies in our practice with FACE that had some evaluation of their hearing, and that was 12 patients. And so in only 3 out of those 12 had hearing loss that I would judge to be related to their FACE. And so that's about one in 4 in terms of the likelihood there. So, 1 in 6, 1 in 4, but this is common enough where I think it's something that's important to have on the radar. As I said before, the left side was pretty much exclusively affected. Not exactly sure what that means. S1 and S3 were the most commonly associated segments. And of course, more research is needed on the course of hearing loss after propranolol initiation. So, how does that impact decision-making around individual patients? So I would say that, when you're having your initial workup, attention should be paid to the hearing nerve on the MR of infants with FACE. As I said before, small lesions can still have an impact on hearing. The protocols that are used to image the brain are typically adequate to assess the internal auditory canal, but I think especially if there was any concern on the ABR, having a discussion about protocoling the MR to get some very detailed images of the hearing nerve and the inner ear, I think is an important thing to do. Second point is many infants with hearing nerve hemangiomas will pass the otoacoustic emission newborn hearing screen. So simply having passed one of your hearing screens does not mean that there isn't necessarily a hearing issue. If there is any hearing nerve findings, then diagnostic auditory brainstem response testing is recommended. And so the testing that's done when babies are born is a quick screening test. The diagnostic test is more involved and looks at the individual frequencies of hearing and the precise hearing sensitivity at those frequencies. So if there are any imaging findings in the vicinity of the hearing nerve, the inner ear, then the patient should get a diagnostic ABR with a pediatric audiologist. And that sometimes in very young infants can be done with baby just asleep, but sometimes it actually does require sedation to do. And then I would say as a pediatric ENT, I think babies and kids should be tested for hearing early and often. There are a lot of different kinds of progressive hearing loss that don't present. And I think that, simply having the diagnosis of FACE, I think is reason enough to have a behavioral test done around 9 to 12 months of age, just to confirm that there isn't any progressive hearing loss. And I would say based on the limited data we have so far, that would be especially important in patients with S1 and S3 lesions. So those are kind of like the FACE specific pieces, but just generally, sort of why is managing hearing loss so important and urgent? And I think, we kind of abide by this notion of the 1-3-6 rule for infant hearing loss, where we want to screen babies by 1 month of age, diagnose the hearing loss and type by 3 months of age, and then hopefully have some intervention by 6 months of age. And the reason for this urgency is that there is kind of this narrow window of brain plasticity where if you are not utilizing that portion of the auditory cortex of the brain, where the part of the brain that's interpreting sound, then that area loses its ability to interpret sound. This is much more important in patients with bilateral hearing loss in both ears. But big studies of kids with single-sided deafness and single-sided hearing loss have also shown that intervention and hearing aids can really help to improve academic outcomes and allow for kids to have more normal development of speech and language, fewer speech delays and things like that. So again, in any case of unilateral hearing loss, which is by far the more common finding in patients with FACE syndrome, there are a number of different options for hearing aids. So this is a picture of a baby wearing what's called an ear level hearing aid or in the ear hearing aid. And again, these can be fit on babies as young as think the youngest I've seen is sort of 5 to 6 months. Bone conduction aids are even easier because you don't have to wear the ear mold. And what this aid does is there's a microphone in that little silver device there, and then the microphone produces vibrations on a transistor that goes directly to the inner ear. So these are a really good option for very young babies. For single-sided hearing loss, so one way we sometimes manage that as well is with bone conduction devices that carry sound not only to the ear with hearing loss, but also the whole skull is vibrating. So this will carry sound to the other ear as well. This is a picture of what's called a bone anchored hearing aid. So this is a little abutment that's actually implanted into the bone of the skull, and then the microphone is sort of attached there. And so that's an option for some patients. There are the current generation of bone conduction devices are sometimes placed under the skin. So this is a device where the microphone sits outside the skin, but then the device that actually vibrates is underneath the skin. So you don't have this percutaneous abutment poking through the skin. And then in infants with profound hearing loss who don't get any benefit from hearing aids, we actually are doing cochlear implantation where an electrode is actually placed inside the inner ear for patients with single-sided deafness. And again, there's data suggesting, again, improved speech and language outcomes, academic outcomes, and those sorts of things for patients who get this intervention. And again, I could do a whole talk on each one of these, but just to give you kind of a view that there are a lot of options, and this is something to discuss with your child's audiologist, depending upon their type of hearing loss. Okay, so again, in summary, up to 1/3 of patients with FACE report hearing difficulties. Hearing loss in patients with FACE is typically related to hemangioma on the hearing nerve, is left-sided, and is associated with S1 and S3 involvement. Many patients with hearing loss pass the newborn screen, so diagnostic ABR is needed if concern for hearing nerve hemangioma exists. There are very good options for hearing rehabilitation. And finally, more research is needed on interventions in course of hearing in patients with FACE. And then with that, I've put my email at the bottom of my slides. I would be very happy to receive any emails that anybody has with questions about any of this, and also happy to take your questions now.